From now to 3 p.m. will be the module about the malunion or deformity corrections. We will have three case present and discuss with our honor panelists. I would like to invite our panelists into the stage.
Yep. So the first is Professor Chang Wak-oh from Kung Puk National University Hospital, Daegu, South Korea.
The second is Professor John from India. And the next one is Professor Yu Ping Su from Taiwan.
And the last one is
our master.
Yeah, our master, our teacher, อาจารย์วัชระพิภพมงคล from Bangkok International Hospital, Thailand. So we have the malunion and deformity session in every year, but this year is very special that we have our international guest as a moderator and as a panelist.
So the first case will be presented by Dr. Kitchai from Washira Hospital, please.
So thank you for inviting me to be a moderator and also presenting the case for this session. I think it's the easiest one compared to the next two cases. Yeah. So this is the female, 65 years old. She has a right tibia fracture with compartment syndrome. She already had the fasciotomy wound. You can see from the X-ray that it have a staple. That is the skin graft on the fasciotomy wound at the lateral side and also the medial side. And the fracture is quite proximal. So it's extended from the proximal tibia, extraarticular, and extend to the proximal 1/3. So this is what the first surgeon decided to do. So he decided to do cross nailing with the suprapatellar nail. Because I think he said because he don't want to open and put a plate because the soft tissue injury. But this is 8 months post-op. So what you see is the failure of the implant, the proximal screw is broken and the fracture turned into non-union. The story not end. So the surgeon decided he don't want to change the nail. He decided to add another lateral plate on the shaft and change the proximal locking screw. But you can see the nail is still prominent because the subsidence of the fracture. Guess, is it healed or not? Who think it's healed? Yeah, no one. So because it's malunion, right? So it's 10 at 12 months after the first surgery. Still pain and cannot weight bearing. And he decided to take a CT scan and also show the non-union of the tibia at the shaft. And the fracture at the proximal location turned into varus deformity. So she came to me, and this is the clinical. I take her picture at about 12 months. You see the varus malunion of the right proximal tibia and non-union of the tibial shaft. When we talk about deformity, we have to draw the line. The first one, the easiest one is the mechanical axis. So we draw the line of the mechanical axis from the head of femur to the center of talus. It can show the varus malalignment of the right lower extremity. And when we have to draw the joint like angle and see where's the deformity. Obviously, it's just the proximal tibia deformity. So we draw the joint angle 84 of the medial proximal tibial angle and bisect with the anatomical axis of the tibia. So it is around 13 degree varus. The location of the bisection of the two lines, we call it chora. The chora is at the yellow star. That is the chora of the deformity. The CT scan, this is the last time the CT scan. I didn't take any more CT scan. It looks like oligotrophic non-union. So yeah, let's start from this slide. The problem with this varus malunion of the proximal tibia and non-union of the shaft tibia with the previous soft tissue condition like this. So I would like to ask our panelists on what is your management for this case. Let's start from Ajahn Bachara first.
Thank you. So this is a year, and what we are looking is about the soft tissue around. So we think about the possibility to do the correction. So the problem is you have one non-union site, and you have malunion. Let's say if you draw this line correctly, it should be some deformity at the proximal. So you have two problems. But you know, in terms of correction of the deformity of the lower limb, it doesn't matter as the joint line parallel. That's okay, even though the deformity in the middle is like an S or everything. So maybe we have to think like this. You can correct the problem in one side at the non-union. Let's say you remove everything. And then you can do if this is still flexible to correct, because the degree is just 13 degrees. So possible to do one side, clear everything, and then the soft tissue on the lateral may be more friendly. You can do the lateral padding, correct deformity at this side, but you have translation. You have to correct this because it has to compensate by translation a little bit. So the plate may be, you have to contour well. So this is a soft tissue fairly one side and put bone graft in. And the second is, you may do this metaphysis. You remove everything and do like high tibial osteotomy. And then you just do non-union at the side with the lateral plate. So you have two plates, tomofix or something like that, and then another lateral plate. I will not put any nail now. I just correct this correction alignment and do bone grafting at the side. This is what I may think about.
Thank you. So move next to.
Okay. So like my own habits, I start with the evaluation stage. So evaluation, there are four things to check. Infections, I think this is no, right? And the non-union, we do have a non-union over there. 3, we have malunion. I think 13 degrees of varus is unacceptable to me. And the 4 is if the joint is salvageable or not. Or I think the joint is okay. So I think my goal is to realign the bone so that the joint line can be corrected, and we need to cure the non-union. And I think the priority of non-union is in advance of the alignment corrections, because if we correct at one side but still have non-unions persisted, it will get trouble. So I look back to the histories why the non-union treatment failed at the first times. Maybe actually the first surgeon didn't put the autogenous bone grafts, or maybe there is some potential infection inside. Okay, so I still keep doubts on the reason of the non-union. Soft tissue to me is relative okay, not so bad. So now the cora is very high. So if there is no infections, I would have two plans. The plan A, I make the high tibia osteotomy, acute correction for that part, and then I plating the non-union side and add a lot of bone graft inside, so that I can correct everything at one time. But plan B is if I go in the first surgery, I go into that, and then I found that could be infections, and then I made a debris or resection the non-union parts, and then I will correct alignments with S-fix, and then do the bone transport or musculates. I mean, either one could be applicable. I think so far that's what I can get in my mind.
So just one question, did he have any fibular bone loss?
No.
So in that case, if you go back to the first X-ray, the fibula is distracted. Okay, so there's a distraction of the fibula. So unless he had some bone loss, it means that he's got distraction at the fracture site, and that's what probably led to the non-union. Okay, so that's the first thing. I think there are different ways of dealing with it, and I think I would go along with either one of the things about how to treat it. I think you need to correct the deformity at the knee, and you need to compress and bone graft the non-union site. So that's what I would do.
Yeah. So, yeah, it's the same opinion. The fracture, made that this malunion, non-union. So, although you made that another line, another coral in the proximal, but I don't think it is really need to make another osteotomy. So we can use the non-union side. Probably there is some fibrous union. We need to make a complete fracture over there. And I may use, shunt spin parallel to the knee joint and parallel to the ankle joint. That's our guideline. As well as I can use femoral distractor to correct the deformity. And then we put I like to use the nail, and that can correct acutely, with a suprapatellar nail. And then this is definitely, distracted, atrophic non-union. We may need bone graft. I like to use autogenous bone graft, but just be careful, since it was a soft tissue injury. So I would like to make the culture and infection focus should be, the examined. Yeah, just in case.
Thank you. So in this case, I confirmed with the lab and clinical that she didn't have any infection. Would you like me to proceed to what I did, right? Okay. So for my plan, I think the non-union in this case is caused by the combination of the mechanical and biological of the fracture, and also because this tibia is off the axis, so it has a varus deformity here, and the mechanical axis is here. So I think I want to correct both alignment and correct the non-union at the same time. So I do exchange nailing for I think is it wrong? Is it oligotrophic non-union of the tibia with exchange nailing and bone grafting, and correction of the mechanical axis of the proximal tibia by medial opening wedge osteotomy at cora. So we have to open on the lateral side and remove the plate and remove the nail, and then I remove some fibrotic tissue at the fracture site through the lateral incision, and still some broken screw that I cannot remove from the nail. And then I just do opening with osteotomy. I do it just a little bit below cora, about 1 centimeter, to confirm that I have a space to fix the proximal tibia with the nail and plate. So use the same instrument of the Tomofix for opening wedge. So after putting in the osteotomes like this, but be careful that you keep the lateral cortex intact. And if after you correct the alignment, the joint is parallel. Right now, I use laminar spreader to control the wedge, and just provisional fixation with the Tomofix. And then I want to insert the nail, but I have this time I go with infrapatellar nail because I have to remove the nail from the infrapatellar. The first surgeon do it suprapatellar. So I put the blocking screw because the nail will have to be in the different pathway, and insert the nail, create the new entry point, and pass the guide wire. And at that time, I ream to 13 millimeters and insert a bigger nail to 12. And insertion of locking screw and proximal locking screw, and finalize the Tomofix. And then I bone graft the osteotomy side and also bone graft the non-union side. So this is the final alignment. This is the clinical picture of the wound. So this is the post-op X-ray. At 3 months, I allow her to put a toe touch weight bearing for 3 months. And at 3 months, the range of motion is okay. At 3 months, the fracture, I think it's progressed with, you can see that the inner cortex have some bone bridging. And especially in the lateral view, around the nail, you can see some bone regeneration around the nail. And the pain is less. So the patient, at 3 months, she said she walked with walking stick, and she can put a weight on it. I think she said no pain. Yeah.
So do you have like a longer follow-up of the final X-ray? Because I concerned about the status of healing.
Not yet. It's still, right now I think it's around 5 months. She will follow up next month.
So any reason for using a Tomofix and not another T-plate, the standard LCP T-plate, because the osteotomy is much lower than what you would do for the Tomofix? And
Yep.
also the direction of the screws, if you can change the screws in the LCP T-plate, you can't change the direction of the screws in the...
So for the T-plate, I want to use the bigger screw for 4.5 or 5 kilo. So that what I have is Tomofix, the long one. But for T-plate or 4.5, the other company I don't have it in my hospital.
Do you think did we correct the varus enough?
I think it's still a little bit worse.
So can you go to the post-op X-ray? Yeah, because you are still using the previous entry. That the nail in the proximal tibia, it goes to the lateral. So we should go to the medial side.
Yep.
So otherwise you cannot correct that. Although you did the HTO. So for me, it's a difficult one. If you have already made the entry hole, whether it is a proximal tibia or the proximal femur, you should block that, the previous entry. And
Yep.
previous holes of the nail pass should block that. And then you can go to the nail to the medial side, and then automatically you can correct that deformity. So yeah, why do we have HTO in the old ladies? To make it valgus. Intentionally you need to make valgus. Can you see that the standing X-ray, the final one, standing? Yeah, say even the left side, you need to have 5 years later, you need to have another HTO on the left side again. So anyway, to correct the deformity, we need to overcome the previous, the mistake. Yeah, that's my concern about the deformity correction.
Yeah, so thank you, CMU, for very, very beautiful tricks to make it focus by the nail, right?
Yep.
May I ask you, Ajahn Kitchai, what is your mind during that planning that you use the plate, HTO, yes, agree, and then you just think nail or plate for the mid-shaft non-union? So what is in your mind and what's your reason?
I think I question about the healing of this one, but I think you can see that he have a lot of callus. I mean, outer cortex have a lot of callus. So I think the fracture is trying to heal and then I open up at that time to remove the plate, and I see a lot of callus, only some fibrous tissue inside. So I think it's ready to heal with more stability. So I think stability for the tibia, the best one is the nail, and rimming is also increasing enhancing the endosteum healing.
For the rimming, yes, I agree that rimming product may help. But for the stability of this hypertrophic non-union, I may consider plating, because this is about instability more or less at the non-union side. So what I need is a mechanical stability, because it is instability. So if you think about the non-union hypertrophic, I may provide more stability by plate. But okay, reaming products, that is one reason. Thank you.
So one of the problems when you deal with proximal tibial fractures is you make the entry point a little lateral so that you don't get valgus. So what he said is, in this case, you want valgus, so you need to make your entry point a little more medial.
Yeah, I want to raise another question. Always focus on the non-union because I always think, the priority is infection, non-union, and then the corrections. So actually, we used to calculate the non-union is either hypertrophic or oligotrophic. But I think that's kind of inappropriate enough. It's not appropriate enough because usually, at the same site, somewhere is oligotrophic, somewhere is hypertrophic. Yeah. So I would like suggest the anisotrophic because in material science, there is the term anisotrophic. That somewhere is atrophy, somewhere is hypertrophy. So, but no matter how, I think for this non-union, it requires more stability and the bone graft. And for this, actually failed replating, I don't think that the reaming can bring too much bone debris or viable bone debris into the defects. So I think if I were you, I would use that the dual plate combinations and the large amount of autogenous bone graft.
So even if I use a nail, I'd use a plate across the fracture so that you're giving the fracture more stability. Plate is ending almost at the fracture.
Any question from the floor?
I'm Jidapa from Serat Hospital. So it's an interesting case. I was like to, I noticed a little bit like pre-op X-ray. I think she has a rotational deformity as well.
Yeah, it's a good point.
Yeah, thank you.
Some
So
internal
I think you may need to correct that one, but doing the opening wedge is only one plane corrections. So I'm not sure if you think that we don't need to correct that or.
I think a little bit internal rotation
From the
deformity,
scanogram.
Right? Yeah. Clinically, she have it, but she didn't complain about it. And then let's take a look at the clinical. I think it's a little bit inchoing that you mentioned, but it kind of compensated. Yeah, thank you for your comment.
Right.
Yeah, if you want to correct it, I think you can do it at proximal tibia and rotate. The rotation of at the osteotomy site.
So if we have more than 20 degrees of rotational deformity, so we can correct at the same time, so acutely, so that's not better. Yeah.
So during the correction, how you control the rotational correction during the surgery?
Yeah, what I do is, the parallel to the knee joint, compare the other side, the fibular overlap and AP, and then put the one screw here. And if the leg is internal rotate, I external rotate and make an AP and another shunt screw. And then after osteotomy, we can correct the AP, then automatically we correct that. And also, if we have a distract on the medial side, we can automatically correct all the barriers. So then put the suprapatellar nail, and then if it is not enough to have stability, we can add another plate. Yeah.
Yeah, thank you for so much selfless share. So that's everyone here.
Yeah.
The floor can bring it home.
Okay, can I go home now?
I go with you.
All right, thank you for a very interesting case.
Okay.
So shall we move to the next case?
Yeah, thank you very much.
Thank you.
Thank you very much.
Thank you.